Hello and welcome to a special interview for The Wire. How worrying is the second surge of coronavirus cases, and what more does the government need to do to tackle them? Those are the two key issues I shall raise today with one of India's foremost epidemiologists, Professor of Epidemiology at the Public Health Foundation of India in Bangalore, Giridhara Babu. Professor Babu, as of today, Friday, the 26th of March, coronavirus cases are increasing by almost 60,000 a day. And in fact, over the last 1 month, the 7-day rolling average of daily cases has increased by nearly 330%. So let me start by asking you, how worrying is the present situation?
Karan, thanks for having me on this show. I must begin saying that if you had asked me a week ago, I would have said probably it's unclear. But today, I can look at the numbers and say the situation is definitely concerning. Mainly because the reproductive number, which means how many number of people, 10 people infected will spread to, has gone to 1.65 now. The last time this was similar of in 1.65 was early May of 2020. Since then, the reproductive number has only gone down. But beginning of February till now, the reproductive number has only increased, which suggests that there is an increased transmission going on in most places, and not just one. 19 states in the country have more than one as the reproductive number. This is a clear indication that as a country, we are in the second wave, and in the days to come, we will expect steep rise in cases.
So this is therefore a worrying situation.
I must say yes, unless we take actions, this might sort of spare it into a bigger crisis. So we can avert it if actions are taken now.
Do you have any sense of why this is happening at the moment? Is it because, as the government repeatedly says, that people are being careless, COVID behavior is not being observed? Or is it because infectious mutations are now beginning to spread, regardless of whether they've been imported from UK, Brazil, or South Africa, or whether they are homegrown? Which of the two, infectious mutations or careless behavior?
I think it's a bit of both. Let me explain. So, to begin with, there is a change in pattern in three important things, which is host, agent, and the environment. So, I'll start with the agent, which is the virus. There is definitely presence of more infectious strains in the country, not just which are imported from outside, but are also the variants of concern emerging within India. Therefore, their infectiousness is probably higher compared to the earlier strain, and that might be the agent related factor. In terms of host, there are two important things that we need to understand. COVID appropriate behavior has gone down not just in these states which are seeing the surge, but all over the country. So, therefore, it cannot explain only few states having surge in cases. That is a given, that is a constant in most states. But I'm also worried about another thing of waning antibodies, even when people had infection in the past. Can reinfection be a part of the whole story? And what proportion of people are having this reinfection? So, host factors are these. In terms of environment, so I said agent is one factor, host, and finally the environment. This is the classical epidemiological triad of any outbreak. Regarding the environment, pretty much everything has opened up, and there's a general feeling that the pandemic is over, and since vaccines are here, maybe we can rejoice. But what we are ignoring is most of the super spreading events are only increasing in the last few months. So therefore, we have created a conducive environment where the virus is probably getting infectious. We need to just do more studies to understand. The host response is unclear, and environment is very conducive to promoting the fast spread of the virus.
Now, within this, Punjab has reported that 81% of 401 samples sent for genome sequencing turned out to be the UK variant. What are the chances that the same percentage could be true of other states like Maharashtra, which also have a lot of people arriving from the United Kingdom?
It is possible, and not just Maharashtra. the UK variant might have spread to many states, but even within Punjab, what it clearly suggests is that there is a sort of community spread of this particular strain. Now, what's happening is we are unable to find every cluster. The problem, the limitation with the genomic sequencing is that we have to concurrently evaluate every cluster of cases and then see at least 5% of whatever samples we want to do. If it is done well throughout the country, we can pick up which particular strain it is. So Maharashtra and Punjab have the UK variant, but I'm also more concerned about the other variants in the country. As a result, there might be a cluster of different areas having different strains. Therefore, circulation is locally probably having different dynamics.
Let me pick up on that last point you're making. Maharashtra has reported, in fact, the government of India has officially reported that in Maharashtra, between 15 and 20% of the samples sent for genome sequencing are what is called the double mutant variety. That is very much a homegrown variation. How much of a serious concern is the double mutant in Maharashtra? Because if 15-20% of cases are the double mutant, is it an exaggeration to say it's a concern or is it not?
No, it is concern, but it has to be validated through proper analysis. And not just this, the Niman's laboratory in Bangalore has given the result saying that there is a local variant within Bangalore, which is also present in Andhra Pradesh and Telangana, which is a different variant. Now, whether these variants are highly infectious or not can be understood in two ways. One, we need to do in vitro studies to know what the infectiousness of these strains are compared to the earlier variant. And we also understand contact tracing, what proportion of people who are getting cases from the primary cases are getting because of this variant. These investigations are necessary to say whether the Indian variants are equally infectious as UK variant or more or less. So that judgment can be done only by careful assessments.
You're making a very important point. How infectious and therefore how much of a concern the Indian variant is depends upon doing tracing to see how much it spreads. Is that tracing, is that investigation happening sufficiently quickly, or are you concerned that it's happening slowly?
Currently, there are too many things happening, at least when it comes to health workers. They are supposed to do vaccination, they also do testing, then also they should do contact tracing. Unless whole of society approach is involved, where different departments and different people are involved in contact tracing, currently I must say this is not effective, or this is not to the expected level in terms of understanding how infectious these strains are.
You also spoke about a variant which is homegrown that has been discovered in Bangalore, which has also been seen in Andhra Pradesh. You said the NIMHAS laboratory had established this through genome sequencing. How much of a potential concern is that?
So far, from whatever there is a preprint publication from the NIMANS. So far, what it suggests is that most of the local outbreaks in Bangalore, of 47% of them, are because of this variant. The important point to consider is if we were to investigate clusters not just in Bangalore but in all the parts of the state and country, then we might be identifying different strains. And then once we do contact tracing and in vitro studies, we would probably know which of these variants are more infectious and which of these might be immune escape variant.
So we have a potentially very concerning situation. A, we have cases increasing nationwide by almost 60,000 a day. Secondly, we know that the UK variant has come and has perhaps established a level of community spread in Punjab, and it has probably spread to other states. And then C, we have a double mutant homegrown variant in Maharashtra, which we believe is spreading there. We just don't know how fast because the testing isn't being done adequately and certainly not fast enough. And we have a similar concern about a homegrown variant in Bangalore, where again we need to know how quickly it's spreading and how infectious it is. So this is really a situation of growing concern, and unless we speed up our investigation, we will remain in doubt and in the dark.
Yeah, so I think at this stage, what we need to understand is if urgent actions are not taken in terms of understanding how these variants behave. At the same time, step up our containment measures in trying to limit these spreads only locally and not spread to other parts. And finally, catch up with the vaccination pace, then the situation would be different. So this is a situation where we need to be prioritizing COVID-19 response over several other things that we are focusing right now.
Now, the government, against this background, has already announced two steps. First, it has announced that starting the 1st of April, everyone over 45 will be entitled to vaccination. And secondly, it has said that the gap between the two Covishield vaccinations has been extended up to 8 weeks. I know these are not sufficient measures, but are they good, sensible steps to have taken?
I'm very happy the government has taken both the decisions, and these are very important and necessary steps. And as you said, Karan, these are not sufficient. We need to be doing more in terms of ensuring that the vulnerable age group and those who have comorbidities are covered as soon as possible.
Let's come to those additional extra steps that are urgently needed and they must be taken by the government. In a recent article you did for The Hindu, you identified several such steps. I'd like to take you through them one by one. To begin with, you said, by expanding participation by private health facilities, it would be possible to cover more than 7 to 10 million doses per day. At the moment, our average tends to be around 2 million a day, although on 1 or 2 days we've hit 3 million. You're saying if we can expand the role of the private health sector, we can expand coverage to 7 to 10 million doses a day. Can you explain how this can be done?
Yeah, so the premise, the rationale for this is if we were to cover the 300 million people in the next 1 or 2 months, then this speed is obviously required to prevent deaths in this country to the whatever compared to the earlier. There are 300,000 trained vaccinators within the public health sector, which are, this is the strength of the country. And using these workers, we have eradicated polio and accomplished many other tasks in immunization. They're all trained in giving intramuscular injections and in most of the remote places. So they by themselves can do almost 3 million per day if they were to do 100 vaccination per day. To do 100, they need a very strong microplan, but that is something that I can explain later. The remaining, if you look at the workforce within the private health sector, even if we assume there are at least 10 lakh health workers, including the doctors, nurses, and all the people who are qualified to give intramuscular injection, even if we use part of them, half of them, at least 500,000, and they doing 100 each is 5 million per day. So 3 plus 5, 8 million can be done just by expanding the optimal workforce that we already have.
In other words, we have the people in terms of 300,000 trained vaccinators. We have 5 lakh health workers, doctors, nurses, etc. in the private sector. They are all capable of giving vaccinations. We have to use them. The effort has to be made to reach out and use them. And that you feel is an essential effort.
That's very essential at this stage because if we were to curb the ongoing transmission, two things are very important. Even before vaccination, we need to step up the containment measures so that this will not boomerang into a greater problem. So therefore, isolation of cases and ensuring test, track, and trace strategy goes on fine is the first requirement. Next is expanding the vaccination process to the speed required will then give India the advantage it had for all these months.
Now, the second thing that you mentioned in that Hindu article is that we need to give immediate emergency use clearance and authorization for all the vaccines that have internationally established their efficacy and their safety. That would mean that the Modernas, the Pfizers, the Johnsons, the Novavax, and presumably perhaps even the Russian and Chinese vaccines should be cleared without having to go through what are called bridging studies. Is that right?
Bridging studies would be necessary to prove the efficacy in the Indian context in terms of safety, immunogenicity is also important. But Covishield was approved even before the results of bridging study were made available. On that premise, for emergency use authorization, we need to have a vaccination policy for the country in terms of what's our goal, what proportion of people we need to cover in the next few months, and for that, how many vaccines we need. And for that purpose, we need vaccines under emergency use authorization. Currently, there are already two vaccines announced by the government of India that they will be including in the next 1 month, which is the Sputnik vaccine and also Zydus vaccine. And if we were to expand this basket and then have more vaccine candidates possible under emergency use authorization, then at least the supply side is met. There is demand side which has to be met with the microplan.
So you're saying do what you did with Covishield. Allow the Pfizers, the Modernas, the Johnsons, the Novavaxes to be available for emergency use in India. Let them carry on doing their bridging studies simultaneously. But just as Covishield was made available and authorized before the bridging studies finished, similarly, these other vaccines can be made available before their bridging studies finish. Bridging studies don't have to be a precondition for authorization. They can happen simultaneously.
Yes, correct.
Now, a third step you suggest, and I'm quoting you from your article, is any person who is 18 years old should be permitted to get any vaccine approved by India at any designated place and at a fixed price regulated by the government. In other words, immediately open up vaccination to every single adult in the country.
So let me explain this, Karan. Yes, this is what I wrote. And what I mean is an aspirational goal where any person who is eligible should be able to get the vaccine. But in the same stretch, I would say government has to be the assurer of the vaccine for those who cannot afford and make sure that they are the only provider for those who cannot afford the vaccine price. If this is what is ensured by the existing mechanisms and then opening up for all the age groups, then there is a fair balance between those who can afford and those who cannot. Otherwise, what's going to probably happen is only opening up without focusing on those who cannot afford, then actually widen the inequities that the country already has in terms of health system access.
You're very clear, and it's a very good point you're making. The government's responsibility to ensure that everyone who cannot afford a vaccine still has a vaccine will continue, and the government must do everything to ensure that every single Indian, regardless of whether he or she can afford it, gets a vaccine. But on top of that, it's important that every Indian over 18 has a right to get a vaccine, and as you say, at any designated place. So a really comprehensive opening up, whilst guaranteeing that those who are poor and can't afford it, the government takes care of. Both happen together.
Yes, that's correct. And especially when most of the organizations and companies are ready to vaccinate their workforce, this will actually increase the proportion of people who are having antibodies, which is a good thing for the country. I think this is the time when the country should consider.
Now, as of Thursday, yesterday, the 25th, it's established through newspaper reports that 80% of the cases are in 6 states, 74% are in just 3 states, those 3 being Maharashtra, Kerala, and Punjab. Even if the government disagrees and does not open up vaccination for everyone over 18, do you think they should at least blanket vaccinate these 3 or these 6 states?
This is a matter of strategy which has to be finalized, Karan. But in the earlier immunization campaigns, for measles rubella campaign, 3 to 4 states were covered in one block. So there is precedence that this kind of strategy of focusing on high risk states and then moving on to moderate and low risk has been done for the other vaccination programs in this country. So yes, it is a possibility. But even in order to do that, if you look at the number of states which are having more than one reproductive number, there are 19 states. So very soon, if this is going to be all states, then it becomes difficult to prioritize which will get first, which will get later. So the strategy has to be finalized by the vaccine expert group and also the end tagging.
In fact, bearing in mind what you just said, that the R number in 19 states has crossed 1, it makes sense to do what you first suggested. open up vaccination to every single adult over the age of 18. That would be the fairest, simplest, and most effective way of tackling the problem because, in fact, you can't identify any longer just a handful because that handful has become 19 states, hasn't it?
Provided the government is the sole provider of vaccine for all those who cannot afford, those who can't afford can be guaranteed by the government. Rest of the people can find on their own where to get vaccinated.
Now, you make a fourth suggestion in that Hindu article as well. You say, do away with pre registration and over reliance on the CoWIN app. And instead, you say, you need simple offline walk in vaccination, and this should be done with paper based collection of details. Can you explain this a bit further, please?
Karan, I like technology, I love apps, but then when it comes to vaccination, the country has been the global leader by using only offline kind of approach for polio and other programs. So therefore, I believe the public health programs for scalability have to be very simple. I have nothing against COVID. But when you make pre-registration mandatory, there is an additional step involved. Instead, if everybody can walk in and then get vaccination done, and then these details are entered onto COVID as an offline method, how all the programs are done in the country for other vaccination programs, the same method can be adapted here to speed up, to increase the pace of vaccination that the country is doing.
And in fact, you make a very good point. We have had great success with vaccination earlier using the offline method. Keep it simple. We know how to work it when it's simple. Don't add in other features which make it more complicated and slow it down. That's a very good point. Fourthly, or rather finally, you say, you believe the government must start mobilizing people to take the vaccine and to overcome vaccine hesitancy. And you say this can be done by micro planning done together by the central government and all the state governments. Can you explain how does this micro planning work?
So this is very basic element of all the vaccination programs. What microplanning does is it lays out a clear plan to map all the beneficiaries by designated place to a designated session. So, for example, one ASHA caters to a population of 1,000 people in rural areas. She knows exactly where these houses are. All she has to do is she has to tell them this vaccination session is catering to these 1,000 people. And that is micro planning, which includes human resources management, logistic management, and maps that will have clear details of how to cover the entire country. This is the same process that we have adapted for polio eradication, measles, and rubella. Now, once the micro planning is in place, mobilization has to occur, saying that, okay, from these 1,000 population, I will take those who are eligible to a particular session on a particular day. This is told to them to please come there. Maybe 80% of the people come on that day, 20% don't come. Then we will mobilize those 20% through other means. Currently, what's happening is there is this bulk upload of beneficiaries on CoWIN, and that is sort of given to the centers. So it is a top-down approach where we are expecting people to come there. But let me tell you, in this country, we do not have healthcare seeking behavior to that aspect where people on their own can go to a COVID vaccination center, know exactly when to go and get vaccinated. So the very, very small proportion of people can go without mobilization and without micro planning. We have to shift from that to the time tested strategy in India, which focuses on a very strong micro planning and strong mobilization efforts. But for this, I don't think government alone can do this. We need participation of all of society approach. The government has been saying all of government approach, fantastic. But what we need is all of society approach now.
You're making a very important point. This sort of micro planning, using ASHA workers in particular, and bearing in mind the fact that we have one ASHA worker for every 1,000 population in the rural areas. This was the micro planning system that made polio eradication, measles and rubella vaccination so successful. Use the system again. And it's the best way of reaching out to people, motivating them to take it, and ensuring that those who missed it out in the first round get covered in the second. Now, your last point you say is that this needs to be mentored and monitored each step of the process. Should that mentoring and monitoring be done just by the central government, or should we also, at that stage, rope in institutions like the World Health Organization?
Yeah, just before I get into this, Karan, I just want to clarify. In the urban areas, we do not have ASHAs the same way as we have in rural areas, but all the earlier campaigns have used nursing students and other volunteers in the urban areas. That's also equally important. And again, to do all this, we need collaboration, and collaboration will come from many organizations. And World Health Organization has been a leader, at least in terms of polio eradication. If you look at how India, just to for the audience information, India is the global leader in terms of polio eradication and surveillance for the polio. And whatever India has followed has been almost emulated in most countries. The same set of officers, surveillance medical officers by WHO, are available throughout the country. They can help in strengthening microplans and then ensuring that the district task forces are run smoothly to ensure vaccination goes on really well. So I think we should be collaborating more and more with more and more agencies.
In fact, you make a very interesting point in that answer. The system to make this happen effectively across the country, covering hundreds of millions, exists. We used it for polio eradication. We were world leaders, and others were copying us. Now is the time to use our own system, not try and invent new systems. We have the system in place, roll it out again. We're getting to the end of this interview, Professor Babu. I want to ask you two more important questions. This worrying second surge is happening as elections are also happening in 5 states. Secondly, there is Holi on Monday. And thirdly, right through April, there will be Shahi Shnans at the Kumbh Mela in Hardwar. And at each of these events, tens of thousands, if not hundreds of thousands of people will gather together. There will probably be no social distancing. It's unlikely they will be wearing masks. And these could easily become super spreader events. Do we need to restrain and curb these events?
Karan, as an epidemiologist, I've been tracking this, and currently, the need of the hour is to prevent any sort of super spreading event as much as possible. This would include all rallies, all closed meetings. This will also include in terms of marriages, limiting the number of crowd. So preventing the crowd formation, ensuring that many people do not congregate in one place is absolutely the most important thing right now. And when it is not possible, like how the Karnataka government has done, it has limited the number of people for a very famous Dasara festival that happens every year. And those rules were strictly followed. When you do physical distancing, and even aerospace was done under very strict physical distancing norms. So prevention is best. If we can't, at least we should ensure that there is a limit in number of people allowed who are following strict COVID appropriate behaviors.
So when the new chief minister of Uttarakhand says, which he did just a few days ago, that faith in God will protect you, that is the wrong approach. Instead, he needs to make sure, at the very least, that people attending the Shahi Shnans at the Kumbh Mela have gone through some form of testing. He's even waived the requirement for testing. That's a second mistake he's made.
I can't comment on that, Karan, but I am a believer in God. Currently, what I would say is that God will help only if we help ourselves, and we should be helping ourselves by wearing masks, ensuring physical distancing, and then ensuring that crowds don't occur in most places.
Do we need to think of lockdowns? Europe and America, when they went through their second and third spikes, reluctantly did impose lockdowns, and those lockdowns did help. Do we need to think of another lockdown before we start hitting levels of 80 and 90,000 infections a day? And remember, we're very close to it. We're almost at 60,000 today. So, do we need to think of lockdowns now?
Uh, I This is a very difficult question to answer, but then the way I would respond to lockdown is that we have two options. One is something as extreme as lockdown. The other is to ensure that all the crowds are prevented and everybody follows COVID appropriate behavior, and the vaccination pace actually picks up subsequently. If we do all of these measures, which I mentioned in the second set of things, well, we may not need a lockdown. But I have a different feeling about all of this currently. People, we want economy to rejuvenate. We want the focus on economy. But if we want to have the economy as a cake, we should be ready to wear our mask and then ensure that we don't eat it. We can't have both.
But let me put this to you. We are not observing COVID behavior. You know that, you made that point yourself. And that's happening right across the country. And even now, when cases are surging to 60,000 a day, people are planning to celebrate Holi on Monday. People are attending election rallies where, let's be honest, the Prime Minister, the Home Minister, Chief Ministers of various states themselves are present. They are not discouraging people, they are encouraging people. And then there are the Shahi Shnans at the Kumbh Mela when lakhs will be present. So, given that people will not voluntarily observe good behavior, should the government enforce it with a lockdown?
Currently, I do not feel a lockdown is necessary at this stage, but we should carefully track at least for a few weeks. As long as the health system is not overburdened with severe cases, there is no need of lockdown. Earlier, lockdown was necessary because we need to prepare our health system. Currently, I honestly feel that we should step up all our containment measures and ensure that those who need treatment are the ones who are getting it. Only when there is a surge in cases, which is beyond our health system's capacity, that's when extreme options should be considered.
My last question. As one of India's foremost epidemiologists, how bad can this surge become? Could we once again experience, as we did last year in September, an increase of something like 95, 96,000 cases a day? Could it get as bad as that?
Yeah, so I see at least two different options at this stage for India's trajectory. If there is a situation where the states take their responsibility and enforce these containment measures strictly, there might be a decrease. Otherwise, the way the cases are increasing, it appears that we might be heading for a peak sometime in the month of May. And whether that peak will be more or less than the first peak, we can't really predict, which will depend on the pace of vaccination and the implementation of non-pharmacological interventions throughout the country. But I'm at least absolutely sure that given the kind of strengths that we have in our healthcare system, we know how to handle surges, we know how to take care of severely sick. So therefore, I'm not really worried about the major adversities of a likely surge as we faced in the first wave.
You're saying a very interesting, reassuring thing. First, you say India will approach its peak around May. Secondly, you're saying we're much better equipped to handle surges, and therefore both illness and death is something we would be able to handle a lot better this time than we did earlier. You're not sure as yet whether the peak when we hit it in May will be as bad as last time or worse. But let me end by pointing this out. In Europe and America, the second peaks were considerably worse than the first. How confident are you India will be different?
Yeah, I am confident compared to Europe and elsewhere, mainly because the greater proportion of the people who are getting infected now are in the younger ages, and generally they'll do well. It's only when the proportion of people who are elderly and comorbidities hit more than the first wave, then it will change. And that's why we need to vaccinate them as soon as possible.
Except Professor Babu, when the second and third peaks happened in Europe and America, again, it was the young in those countries that were a greater proportion of people affected. So we're no different in that respect. I'm not talking about severity of illness or death. I'm simply talking about the size of the surge. The surge, when it happened a second time in Europe and America, was much greater than the first. Are you really sure the surge, when it happens a second time in India, won't be greater than our first?
I mean, nobody can be very sure of what's going to happen. But what I imagine is if the surge is going to be a very steep and all of a sudden, then there is strain on the health system, then people will not get the treatment they deserve. And that's when the mortality will go up.
Okay.
But if this is in different phases, in different states, then we have enough time to prepare and then address the surges.
Absolutely, but there were three ifs in that answer, and I'm just pointing it out. If, and then everything should be containable. But if, and if don't happen, we are in trouble. And I will point out to you, as the Times of India shows on its front page today, that the rate of increase in the surge, they claim, is steeper than it was when it reached its peak in September. So there are some worrying signs that this surge could end up being worse in absolute numbers, not in terms of severity of illness, not in terms of deaths, but in absolute numbers. There are indications that this surge could end up being worse than the one we experienced in September last year. Let's hope that doesn't happen. I thank you for this interview. I thank you for explaining things so carefully and meticulously. Take care, Professor Babu. Stay safe.
Thank you. Have a nice day.